The last characteristic we're going to talk about with compounded sterile products is compatibility. Compatibility can be defined as the ability to combine two or more base components or additives within a solution without creating a resultant change in the physical or chemical properties of the solution or the components or additives. This is important. A CSP comprised of one or more incompatible components may result in a change to the physical or chemical characteristics of the drug. This change is called incompatibility, and it can be dangerous to our patient. Now, some incompatibility has a physical incompatibility, where when two ingredients come together, they form another compound that will fall out of solution or cause a precipitate. Other types of changes of incompatibilities may not be seen. Some of these chemical reactions can occur in a pH change, which won't be seen. So it's important to use your reference books to verify compatibility. A lot of times we get calls from the nurses who want to know if one drug is compatible in the IV line with another drug. So this is an important component. All right, let's talk about some questions. So the first one, a solution with a pH of 7 is considered to be neutral. Correct. Next, this type of solution contains a greater number of dissolved particles than the human blood plasma. Greater number would be hypertonic. Okay, time for some additional questions. Next, we're going to talk about preparation hazards. Parenteral medications are considered to be more dangerous than an enteral product for many different reasons. What do you think some of those reasons are? So, some of the reasons include the blood products are administered directly into the patient's blood supply, into an organ, or into a tissue. So what that means is it's bypassing the body's defense mechanisms. Parenteral injections into the bloodstream have little or no chance of reversal if a med error is made. And parenteral administration introduces 100% of the drug into the bloodstream. So if we give too much of it at once, it doesn't have time to be absorbed and or counteracted. It's all right there, all at once. All patients receiving parenteral fluid should be monitored for nosocomial infection, extravasation, tissuing, phlebitis, cellulitis, embolism, allergic reaction, including anaphylaxis, and Stevens-Johnson syndrome, as well as nephrotoxicity. So these are pretty important components. So we talked about nosocomial infection, so you really kind of understand what that is. Extravasation is when the fluid seeps out, or tissuing is the same thing as infiltration. Phlebitis is inflammation of the vein, which could be a result of the medication being an irritant, or other reasons which can result in tissuing or extravasation. Cellulitis is when an infection gets into the cells and they get inflamed. Embolism is when it could be air generally gets introduced, something foreign into the bloodstream. Stevens-Johnson syndrome, we'll talk a little bit more about that a little bit later. I have some more information on that. To manage these complications, healthcare professionals use various techniques, including use of access points to administer the large volume parenterals. So something that would be irritating to a small vein may be introduced into a larger vein. The most common access point is through a peripheral vein, into which a nurse inserts a needle or catheter or a cannula, which is attached to the IV tubing. So this is the one you normally see in the hand or in the inner part of the arm. The peripheral line is most often used for patients who have a short-term treatment. Patients who require long-term treatment may require a PICC line, peripheral inserted central catheter, and that goes into a larger vein. So short-term, your veins aren't going to get as irritated. Long-term, you continue to do medication. We don't want to use a peripheral vein. It could get inflamed, it could be damaged. So a PICC line has less chance of that occurring. Other access points include the subclavian vein, the superior vena cava, or the femoral vein. These access points are reached through the use of various access devices such as a central line, a Hickman, a Broviac, or other implantable ports. It's very important for adherence to USP Chapter 797 because in light of potential complications, the IV technician has to have strict technique in preparing these parenteral mixtures. The healthcare personnel must be vigilant during their administration to the patients. All right, let's have some questions. Let's talk specifically about compounding. So this chapter, Chapter 8, is on large volume parenteral preparations. These are most commonly known as LVPs. This is when a sterile solution of 250 milliliters or greater is administered parenterally. One of the keys about an LVP is that it is a continual administration. It's not intermittent. The most common LVPs are IV solutions from a standard base, such as 0.9% sodium chloride, which is known as normal saline, dextrose 5% water, commonly referred to as D5W, or a combination of dextrose 5% water with normal saline, which is known as D5NS. We also may use lactated Ringer solution. The most common volumes for these LVPs are really 1 liter, then 500 milliliters, and then 250 milliliters. It is dependent upon a continuous infusion for it to be considered a large volume parenteral. Another term that we use is a drip. So a maintenance bag is a continuous infusion. That's generally going to be your liter bag that's replacing fluids and perhaps introducing electrolytes. A drip usually has another additive medication to it for a specific purpose. So we have nitroglycerin drips so that we can maintain blood pressure in someone who has severe high blood pressure. We give them nitroglycerin as a continuous drip. Heparin drip to maintain the clotting properly in a patient who's hypercoagulating. We can use a lidocaine drip to control arrhythmia. We can use a Versed drip to control sedation. So many of the agents that we use are considered to be, those will be in a smaller large volume, like a 250 or a 500 milliliter base solution, but they're still going to be continuous over an extended period of time. So continuous infusion, sometimes referred to as maintenance infusion, replacement infusion, or hydration, is generally the base solution, and it may also have additives. These continuous infusions or maintenance IVs are used to prevent or correct dehydration and restore electrolyte balance in patients whose condition impedes adequate fluid consumption. So if someone is NPO, if they can't take anything by mouth, if they have long times where they're nauseous or they're vomiting or severe diarrhea. Also replace fluid in patients who have experienced significant blood loss from trauma or surgical procedure. So a fast way to give volume to the blood is to administer an IV bag with fluid in it. And it also helps provide easy vein access for blood draws and medication administration to a patient while they're in the hospital so that they don't have to be stuck multiple times. So as I was saying, a drip is a second type of LVP. We refer to it as a drip. Unlike a continuous infusion, they're given continuously to treat a specific medical condition. Many times a drip is written to be titrated to get the ideal effect. So a continuous infusion large volume parenteral will be running at a specific flow rate, whereas the drip is going to have a goal, like the blood clotting test results come back at a certain parameter, or their blood pressure maintains at a certain level, or their sedation maintains at a certain level. That can vary throughout the administration, so it could be increased or decreased to maintain that effect. Preparing a large volume parenteral, it's important that we have specific procedures that we follow very closely. Those are outlined in Chapter 797. These guidelines are reinforced by your facility's policy and procedure manual. As an IV tech, you bear the responsibility for the preparation and integrity of the CSP. So, as we were starting the other day with learning how to properly manipulate a needle and syringe unit, it's not me picking on anyone, but helping to teach you the proper technique. It's kind of like learning a dance. You have to learn the proper steps so that everything will perform properly. So what seems to be a minor hand placement kind of thing, I need you to think about the fact that improper hand placement, no matter how minor it appears, could potentially cause a significant risk for our patients. So I know it's frustrating as you're trying to get this technique down, but you just have to keep practicing. Practice, practice, practice helps it become second nature. So we'll keep working and we'll get there. All right, some questions.